And so my project was the improvement of hand hygiene compliance. So when I started here in 2017, our percentage was about 87%, which that's not keeping our patients safe. Over the course of 3 years, we implemented a hand hygiene app to try to capture more observations using leaders in the organization. We made ourselves present and educated staff on the importance of washing your hands. When I started, I had an employee tell me, "Why do I need to wash my hands? I put gloves on." And we're like, "Well, we got a lot of work to do." So, over the course of the last 3 years, our percentage has increased to 99%. Obviously, our goal is 100%, so there's obviously still work to do, but we've come a long way in improving our compliance percentage and keeping our patients, staff, and visitors safe.
And so it looks like it's relatively stable up here. Is that true?
Mm-hmm. As of September, when I made this poster, as of September, we were at 99% compliance.
Wow.
And hopefully we just go up from there.
And we've been that way through 2020?
Yes.
Yes, without any, I think there was 1 month, the first month that we started into the COVID, where we had 1 or 2 misses. And since then, it's been almost 100% every month. So.
Fantastic.
So I'm just going to make a note at the end of one of these that says we've looked at the hand hygiene compliance. Thank you, Kristen. Good job.
Very good. Very good.
I'm the scheduler for mammogram here in the Health Center.
Hi, Crystal.
Hi.
So tell us about your project.
So my project is about in the past, mammogram patients get a reminder letter yearly, and so they would call in to schedule their exam, and there was no order at the chart. So I would then have to reserve a spot for their exam, message the provider for them to write an order, and then sometimes that could take up to 2 days. Just their workloads are full, and they have to order higher priority.
They find our old order
And then I would actually have to go back and reschedule the patients and connect them to that account. So by law, patients can self-refer for mammogram, so it's up to facilities if they choose to accept self-referred patients. So Tiffany, Dr. Andrews, all got together and they wrote a policy on accepting self-referred patients. And the guidelines are they have to be over the age of 40, no current issues or problems, and then no implants because those require additional images. And so we got together with Engage and IT and actually created a new order called it's a self-referred order with the provider attached. So the provider gets a report just like always, and
I'm just looking at this.
absolutely.
Exponential growth.
And this is we just had our record month overall last month, 174 mammograms.
Wow.
So
That's a lot.
that's a lot. And our previous record was 136.
Mm-hmm.
Yeah. So I mean, it was a huge jump even within the record. Yeah.
So it sounds like we're probably helping the community members catch an issue earlier.
Absolutely.
That's awesome.
Yeah.
Very good.
Thank you, Crystal.
Absolutely.
Okay.
So I'm Tiffany Peak, and I work in imaging. And one of the things that I do is help patients get scheduled for their breast biopsies. So this initially became a quality project because we would do diagnostic patients and we would tell them that they would need a breast biopsy and that Soft Sound would call them to schedule. And when we do that, we let the provider know to put in an order. Well, that could take weeks sometimes for the provider to put in an order, to get it authorized, and then for Soft Sound to get it and then to call the patient. So in this time frame, the patients are sitting there waiting, very, very nervous, very, very scared, and not knowing when they're going to get scheduled. Now, with the new improved way we're doing things, is that the patient is here getting their diagnostic, the radiologist talks to them and tells them they need a biopsy. We schedule it immediately. Now, what we did to make that happen is we created a new order as well, to where the providers just automatically check mark it, and it says biopsy at radiologist discretion. So that gives me the authority to go ahead and schedule it. So patient gets off the phone with the radiologist, we immediately follow their scheduler and get the patient on their schedule. We give them an appointment card. They leave in knowing they have an appointment and a little bit at ease, knowing that everything's taken care of. On the backside of that, we take care of all of the paperwork, the authorization, and contacting the provider. So less work for everybody, less waiting for everybody, and the patient's
So it's a faster process, it's a streamlined process, and you rolled compassion in to give those results in that quick turnaround time for patients who would otherwise be waiting and concerned.
For all providers, even those not here.
So the automatic order for here is what we created. We also created a outside order with that option for the outside provider to check mark to allow us to do that. The hard part with that is that we don't control them. And so if they run out of the new order and they fall back to an old order, then that might not be check marked. So we just did that just in the last couple of months with the order for the outside providers, and that's our percentage is only at 80s because most of these are outside orders. Or if they needed surgery, sometimes they wouldn't go straight to a biopsy.
So, and it looks like 29 out of 36 biopsy patients scheduled for their procedure at the time of their diagnostic exam. How did that work before? None?
None.
Scheduled at the time of their
No.
exam? That's incredible.
Yeah, so they would have to wait. And then I follow that up over time, because I always keep track of it. But I usually give the patients my phone number, my direct line, because they'd call me and say, I haven't heard from anybody, and it's been a week and a half. And so I have to go back and try to figure out who dropped the ball or what I did.
Fielding off some of that anxiety.
Oh, yeah.
The Lord thank you. Nice work. Thank you.
I'm Aaron DeBart, the project manager over our grant department. And so what we found is over the last few years, St. Pacific has been very fortunate and has won several large grants. And with the portfolio of grants that now is about $5 million, we realized that we need to centralize the effort and provide some more oversight over it to make sure all of these grants are properly managed and being maintained. But then as we go after future grants that are coming up, that we make sure that they align with our strategic objectives. And so what we did is we came together, and one of the first processes we tackled as a grant department is trying to address what grants are there that we need to go after. And so we created this flow chart to be able to help us do that. What we do is as we scan different grants that come up, we look at that and just do an initial survey and say, well, are we eligible? Does this meet something that is within our purview? And go through that, and then once we made that determination that yes, we are eligible, yes, this would be something that could be of value to Summit, then we go in and create a full-up report, do full write-up. We present it to my director of innovations, who then presents it to the director team. They review it, and if they make the recommendation to move forward as well, it then goes to the executive team, and then the executive team to find an executive sponsor then says, yes, we will go after that, or no, we won't. And so that way we're able to make sure that all the grants that we go after in the future align with our goals and objectives and are something that is of strategic value, but also make sure we manage what we do have very well.
Sure, they're well organized and
Yes.
contained. That's a great job, Erin. Beautiful work. Beautiful work.
And I'm Patty Chauffard. I'm the grant specialist on the grants team. And I also manage the Record Implementation Grant that sponsors the work for the Grace Harbor Consortium. So part of what I did is I just recently joined the team this last spring in March, or well, actually April, I should say. And as a result of it, COVID was very active, as you know. And there was a lot of things that were happening that were stalling the implementation work of our activities. And so as a result of that, I was able to go out and have virtual meetings and some in-person with social distancing meetings with the consortium members and understand their needs and their challenges and how we can possibly assist them in addressing it. And then I had to work with HRSA to make sure that any changes that we were looking at and changing our budget to would be accepted. And part of that it was all approved, but part of that discovery in those informational interviews is we needed to really look at the consortium as it was currently. Currently, at that time, it was only addressing opioid and substance use disorders, but you can't really approach that disease and help someone with that in recovery and understanding prevention, treatment, and recovery without really encompassing almost like a wraparound service of social determinants of health and all these other services that are here. And so we came up with the idea of adding pillars of work, and it's very helpful. It's really helping us to expand our membership. We're able to start reaching out to a broader scope of folks in the communities. We're recently just bringing in tribal communities from all around Grace Harbor. I've been working with the tribal liaisons from the state to initiate that. And it's also going to help us be stronger for our future grant opportunities for a second implementation grant that we're looking to do for families and youth. Working with the justice system, they just opened up family court for drug therapy, and so we're trying to really set us up to be strength, in supporting all of those efforts as well. Do you have any questions or comments?
So how long has this work been going currently?
So we are just now in the first quarter of year 2 of the grant funding, and the funding does end in August 31st of 2022. So we don't have a whole lot of time left, but enough time to at least make some difference. We are a good project that we're working on. I'll share with you. It's a stigma reduction campaign, and the folks came up with the slogan of considering a life today. And substance use disorder is a treatable disease, and so with all of the efforts of the SMEs, the subject matter experts, we've actually come up with an idea to do a documentary. So we're in the process of securing a contract with a local company out of Olympia, who their staff actually was from Montecito. So we've got a lot of hometown community people very involved in this work, and we're looking forward to it, because in order to really address these efforts, we have to break down the stigma of what encompasses substance use disorders.
Nice job. Good work, Patty Jo.
My name is Andrea Morrow, and I work in the Shire Health Clerk. This is Shirley, and we are presenting One Key Question. So One Key Question is a tool. It starts a conversation about if you would like to become, how you would become, and preventing unwanted pregnancies.
And helping to prevent healthy pregnancies as well.
Right. So it simply asks the question, would you like to become pregnant in the next year? And then if so, this is kind of the diagram. If yes, you provide counseling, vitamins, if
Prenatal visits.
Right. Kind of gets them going on the right track. If there's yes, unsure, okay either way, or no, then you don't want to get them started on contraception.
With this project, most of our providers became certified to do Nexplanon and IUDs as well, so it's good. People are getting those right away in the clinics. Do you have any idea what the prevalence rates are in our community for unwanted or teen pregnancy?
We did have between the age 18 and 29, 80% are unwanted or not unwanted, but unplanned.
Sure.
Yes.
I do not have Grace Harbor County's numbers.
Right.
But it sounds like it's really meeting a current community need, which is pretty exciting.
Yes, and we hand out this paper every visit to age 13 to 50.
I was going to say, are you working with the young?
Yeah, start at age 13 and up to age 50. Every visit they come in and they get asked these questions.
One key question was 18 and up, but we moved it down to age 13.
I think
some of those in our
very
community
important.
very important.
Especially in this area, so.
I think all of Grace Harbor County and all of the states.
Right, that's true.
Yeah, I found this to be true in 1976 in Collin County. So yes, I think it traverses all demographics. Yes, it does. Absolutely.
Because people don't really think about it until they're asked it. And then you're like, oh, well, maybe, or no, or.
These questions are important, especially since referendum 90 is just now starting. It's not all parents that are up front.
No. Yep. Well, thank you very much. Do you have any questions?
No,
Great work.
I think they've answered it.
I'm so proud of the work that you folks do, truly.
My name is Paula Young. I'm a medical assistant here in the Wellness Center in the clinic, and I actually work in pediatrics. And then Charlotte is our supervisor.
Very good. You want to tell us about the work that you've committed to?
Yeah, so with Bright Futures, we with Dr. Hutton and Jessica Jerson, ARMP coming to Summit, they realized that not all of everybody was documenting well child question checks the same way. So we wanted to standardize when we were doing what at what age. And so by using the Bright Futures and the periodicity table, we are meeting the standards like when do we screen mothers still for postpartum depression and how to get the mother help with that? When do we screen children for autism? At what ages do we ask the questionnaires for that? And so we met together, we brainstormed, we bought the rights to the Bright Future stuff, and then we created the documentation that we now use in our EHR.
Wow. That's incredible. That's a sort of a groundswell from scratch movement. Good job. It really is. Yeah. So
And it's working very well.
It is.
It is. Good.
We've been pediatrics, we've been using it since the end of May, and then we rolled it out to all providers in July. And so since then, we've had to make a few changes that we noticed that were to fix a few things where there was some snags in the process. But having everybody's eyes on it, it has really helped develop the project even more. So that we're at now the standard that we are with our documentation.
And when we brought on Bright Futures, we also brought on a new vision screener that can screen from a very young age up. And
We also have the hearing that we can do at 2 days of age, so they don't have to go back to the hospital if they failed their hearing test. We can now do that 2 years of age and up. The vision screener, we can do 6 months of age and up if there's any concerns about their vision before the age of 2, because at 2 we start everybody getting a yearly vision and hearing test.
and we've actually already probably saved the vision of a very young child from that vision screener.
About a
So-
15-month-old that we wouldn't normally test until they were in elementary school when we did the site, the 20 distance screening.
That's incredible work in this little community.
Yeah.
Nice job. Yeah, nice job.
I'm Elizabeth Heimbach. I'm the lead RN in the MAC clinic for Summit Pacific.
Kathy Moore, RN in the Mac Clinic. I'm Amber, I'm the medical assistant for the Mac Clinic. Awesome, thank you.
We chose harm reduction through Narcan distribution for our poster, mostly just because we feel like it's made the most impact in our community as far as our patients go. Because we are a medication-assisted treatment clinic that deals with primarily with opioid use disorder, making sure that Narcan, which is an opiate reversal drug, is available to people who use opiates or maybe in the vicinity of opiates is fairly important to reduce overdose deaths. So that's what we're currently working on. At this point, we are attempting to make sure that every patient that is seen within our clinic leaves our clinic with a prescription of Narcan sent to their pharmacy. If they're unable to fill that prescription due to being underinsured or potentially not being able to afford the copay for it, we also have started a new grant program through the Department of Health that is allowing us to hand individual Narcan to both patients as well as family members and case members, as well as opportunities to touch those Narcan to save a life.
So I want to ask a question. Tell me about this data. 1 in 12 American adults have substance use disorders. How many do you feel like we've impacted here? What's the depth that we've been able to reach in this?
Current numbers, right now we have 502 patients within our MAC clinic. Out of those 502, our retention rate, meaning we've seen the patient more than 3 times, is at 71%.
That's unheard of.
So it's, I think that potentially Narcan is helpful. I think patients enjoy having the ability to come and just simply ask for assistance or having family members being able to come up and ask for assistance, even if they don't have a family member within the MAC clinic. But I think the real reason people come back is because at Summit it's a little bit more than just healthcare. It's also healthcare with connection. It's about you as a person. So
Certainly anecdotally, that's what we're hearing
Yes.
in the patient stories. I mean, that there's a good deal of compassion and being shown without sort of what can lead to stigma.
yep, that's what we're working on, reducing stigma. And part of that is making awareness a little bit more broad and talking about things like Narcan that can save a life in a more public setting rather than kind of behind closed doors and closets with people with opioid use disorder, as this medication can also save people who are on medication from their doctors that are prescribed that are maybe don't consider themselves to have an addiction or a use disorder currently.
Incredible work, ladies. You should be very
They did it. Well, they did this. This is their
That's
work.
awesome.
That's their work.
Incredible work, ladies. Incredible work. Okay.
Oh, for all.
Yeah.
Fantastic.
Thank you. Okay. Any last words?
I think that's it.
Okay, thank you guys. It's nice to meet both. Nice to meet
Absolutely. My name is Natasha Chapin. I am the clinical population health manager here at the Summit. This is an initiative that we started mid-2019 to help address suicide rates in the county. The state actually did a big state initiative about 5 years ago, and this was Summit's efforts to help partake in that. We actually implemented a zero suicide risk protocol within our clinic with the help of Dr. Ursula Whiteside. She worked with us to develop a kind of modified PHQ-9 and BRE collaborative type efforts, which allowed us to identify our patients that were at risk for suicide. It may not actually be in a crisis, but we're close to it, so we were able to identify those patients and be able to help them while they were in the clinic, so we just don't have to send them to the ED and send them home without safety measures. We're a little cautious. I'm going to intervene this for a second and help. So a PHQ-9 is a standardized, nationally recognized mental health illness screening tool. Yes, thank you. So after we implemented it, we were able to create a data dashboard to capture, recognize how many of them were actually handing out or assessing patients. We were able to also recognize certain age groups, and we targeted our last question on the tool, and that was kind of our key or trigger of like, okay, we need to implement now and start our zero suicide safety planning and walkthrough, which just the provider would just ask us questions to kind of help gain a perspective on where the patient was at for that day and what safety measures need to be put in place, if any. So we did identify some different age groups. We noticed that our young adult age group was actually at a higher risk for being suicidal than our mid-age range. Yes. Yep. Unfortunately, our younger adults and even our pediatric kind of hung in the higher percentage rank. And as you can see, like around like our COVID time, we did see a decrease in numbers. Unfortunately, that was because a lot of people didn't come to our clinic. And then we saw kind of a spike. And hopefully, as we do our next little phase of quarantine, we have still made access for our patients with our virtual visits. We're a little bit more prepared this time, so we don't miss a lot of these even depressed patients at this time.
Excellent. So you're innovating. As the world changes, we have to keep changing.
Absolutely.
Great work, Natasha. Thank you so much. Thank you.
Sure.
Entails.
Nice to meet you guys. I'm Karen Thomas from KT, and I am an ER nurse. I'm also the program coordinator for the cardiac trauma and stroke programs for the hospital. We did a aspirin quality improvement piece that started, I guess it was in 2018. We recognized that the AHA states guidelines that any patient that comes to the emergency department with chest pain or acute coronary syndrome symptoms should receive aspirin during their stay. We recognized early on in 2018 that those numbers were pretty low in our department. It wasn't either being documented or it wasn't being given. Either way, it wasn't there. So we implemented some changes early on. We asked our providers and our nurses to document the care, educated them about the importance of the aspirin administration, and then continue to monitor that number. Our numbers continue to stay low. Then our next step was to edit EMR changes to the order sets. Any patient that comes into the emergency with chest pain gets what's considered an order set from either the physician or the nurse that specifically states that aspirin had been given. That worked, it brought up our numbers a little bit because then patients were either receiving it or not receiving it. Probably at least ordered. So we took up yet another notch, and then we put into the last EMR change that we put in 2020, in May of 2020, was we put into the RN assessment flow sheet of whether or not aspirin was indicated, and if it was indicated, if it was given or ordered. And it was made basically as a hard stop, so they had to answer the question. So that really shot our numbers up through the roof. It was kind of a reminder to the nursing staff as well as the ER staff or to the ER physician staff that if it hadn't been ordered, then it needed to be ordered in order to for the patient. Since May, then we've been greater than 92%. So pretty impressed with those numbers.
That's awesome. Fantastic.
Thank you.
Steady progress, one way or the other.
Yes, it is. It is.
I'm Jared Hoskinson, and I'm the health coach here at Summit. And welcome, Georgette. Always lovely to see you, Cecelia, Brendan. So basically, Summit Care. I don't know, have you guys heard of Summit Care at all yet from around the clinic? Yes, of course. You've had first-hand experience, I know. So this will be easy for you to understand, but for those who have never heard of Summit Care, basically, here at Summit in Grace Harbor County specifically, we've identified opportunity for improvement with our preventative, holistic approach to our medicine, our patient care. Right? So last year, before I got here last May as the first health coach with our entity. We did a short pilot, if you may, for the Summit Care program with the Summit Care philosophy. And essentially the whole idea is to create a care team for our patients with now is the health coach, the PCP, whether it's an allopathic or naturopathic provider, so we get the opposite and the opposite scope of care as well. Physical therapist, pharmacist, and dietitian, which is another new resource we've added the past year. So basically what we've done is we've created a model for the patients to come to our care, and we have a care team to have an intake with them, identify the risk factors. We measure their overall level of care that they need based on a stratification scale, which exactly correct. So that's basically, once we've identified all those, the health coach and the patient will get together to create a HAP for your health action plan and create these individualized goals. And from there, that is where we see the care coordination stratification levels, at a lower stratification, less risk factors. We're not going to have to meet as much. We'll meet, once a month if you may. As opposed to maybe level 4 or 5 where it's a high risk factor, higher stratification patient. They're going to meet with me as a health coach more frequently for these preventative measures, as well as have the opportunity to meet with the care coordinator as well. For any chronic diseases, diabetes, hypertension, things of that nature. So, all in all, over the course of this past year, we've had really good success. We've measured success in many different ways. One, our retention, we started with 41 voluntary patients. We're down to 31 today, so about 75% retention. Some of that was based on voluntary opt-out, others based on no longer being employed here, others not following the criteria along with the program. So we do have patient expectations and protocols as well that go along with all this. So essentially what we found so far, really cool notes, we had 4 patients that were smoking when they first started the program, and today we have 0 people smoking in our program. And I think that's just incredible knowing patients I've worked with, how tough of a habit that is to break. And just the feedback, the subjective feedback from these patients the accountability that the program provides and the guidance that it provides has been a tipping point into their success, really, of their previous efforts to quit smoking. And even furthermore, I know everyone, a lot of goals we have around weight loss and weight maintenance. Some people that tons. I'm really proud of these patients that have so much success. Because again, that's a really tough thing to commit to. And then lastly, I really think out of this whole entire program, one of the biggest outcomes we're going to find is the GAD and the PHQ-9. Just because we always get these measures as providers when you come in for an appointment on us. We track this pretty diligently. But what kind of services do we provide to help decrease these numbers or make these numbers a little more pointing in the direction we're trying to go when it comes to mental and emotional health, right? So, and that's what those GAD-7 and PHQ-9 is directly related to anxiety, stress management, and behavior. So if we can measure those and effectively get those numbers to where we want to be, that is, in my mind, the power of this type of philosophy. So, with that said, we still have another 2 months to go with this particular pilot program in January. We'll get all of our data collected. We'll get our final labs, DEXA scans, all the above, final assessments, have a discharge packet for our patients, and from there the next step is to incorporate this philosophy into the clinic, into the workflow with the care coordination team, again with the health coach assisting the lower stratified patients, and the care coordinators working with the chronic disease management patients.
This is so incredibly cutting edge. Good job.
Thank you. I truly believe in the vision. I think we have so many great resources that we can utilize, especially in this setting and community. And it should absolutely, I think this is just the beginning of what we can do. We had a vision back in October when we first started enrolling our patients, and to see where it's come from there to now is exceptional in my mind. So I'm really looking forward to keep up with it and seeing what we can do with it.
So next year you hope to do more?
So the plan is, Georgette, basically we'll take what we learned as far as the logistics. I mean, you're well aware, logistics as far as the flow, what we need as far as stratification levels, and then we've figured out we have a good format and a good solid foundation for as far as again, what the care team looks like and how the patients are stratified and referred to those care team members. We need to see what the health coach capacity is and role when it comes to the clinic setting. And then furthermore, if we need any other, we'll say, resources, assistance in regard to helping coordinate the logistics and whatnot, scheduling, talking about is a health coach service a payable service, those types of things. How do we make profit from these services? How do we still give quality of care? All the above. So, from my team's perspective, from what I've heard, at my level, the next step is to begin to incorporate it with a single care team first. We have multiple care teams right now in the clinic. Continue working with this philosophy to hone it, and then as we grow, find other services, either more health coaches, personal trainers, whatever. We'll keep building on this real care team philosophy, as opposed to the Summit Care program. If we're going to call it Summit Care 3.0 or whatnot, to be determined, but it will be the same philosophy. So,
Thank you, Jared.
Absolutely. Thank you guys.